So we're going to go ahead and proceed into a elbow, wrist, and hand exam that you might be doing in practice. Realistically, you have done your history, so you have a good idea of the key areas that you want to focus on, tissue-specific pathology that you want to rule in or rule out, but now we're proceeding into the physical exam portion of your assessment of the patient. Key thing here is that you give an introductory statement. I am going to be performing a hands-on assessment. If anything is painful or uncomfortable, please let me know right away, and don't let me do anything that will cause you further injury. Okay. Okay? First thing, you make eye contact with the patient so they know that you care and mean what you're saying. The second thing is that develops better rapport and gives them an idea for the outline of how you're going to proceed with the rest of the exam so there are no surprises. All right? So to start with, you can go with it ahead and have inspection. What I'd usually do is have the patient just stand or seated, even seated like that, she can be fine, and just put your hands just out at your side and you just want to see how they are like that. Okay? You want to check from side to side. Maybe we'll have you stand up. So she's standing up. I get nice and low like this because I want to be at level for the structure that I'm trying to evaluate. And a couple of key things you want to check here for just general inspection is, again, any bumps, bruising, swelling, or anything like that. I'm comparing bilaterally. You want to see if one arm's more internally rotated than another. Maybe one arm's out to the side a little bit more. Okay? Even the positions of the fingers can make a difference. If you have rheumatoid arthritis, you'll see very different finger positions all the way through, but just general observation. Okay? And you know, you want to check all surfaces, so you can have the person supinate out and have a look at those. You can have the person spin around if you wanted, so have you spin around full 180. Yeah, just like that. Oh, sorry. Yeah, just like that right there. And I'm just looking at the back of the arm, seeing how they compare to the body from side to side. Just general inspection parameters. Again, bruising, swelling, cuts, scrapes, bumps, all that kind of stuff. Okay, we'll go ahead and have you sit down.
You can also evaluate for like an untitled posture. How they're holding themselves. If they're in pain? Yeah,
for sure. And that'll be your key one right there, especially for that upper extremity injury where the person makes their own sling with their body, right? Okay, good stuff. Okay, next thing is going to be palpation. So, what is the verbalization for palpation? I'm going to check the unaffected side first. Why do you check the unaffected side first? You're looking for a baseline comparison, but the real key thing you're trying to get from this is the first contact with your patient should not be painful. One of the biggest pet peeves I have for physicians and therapists who give exams on patients, I have pain on my right elbow. What do? The first thing they do is they jam in that area with pain. What does that do for the patient? You just lost a lot of patient trust and respect by going into an area with pain, okay? Let's go ahead and start on the unaffected side first and just see what the tissue feels like. Remember, the purpose of this is you are giving a basic anatomy lesson. If it's around the elbow, lateral and medial epicondylitis, very common in this area, just start off nice and light. See what the tissue is like here. Gently push your thumb in a little bit, push your fingers in. Think of all the muscles, nerves, right? Median nerve, ulnar nerve behind the midline, radial nerve around there. The vessels coming down, like your what am I looking for? Ulnar and radial arteries coming off of the brachial from the midline here. Moving down, any pain or discomfort there, all the way through the flexors. I'm checking the extensors at the same time. You get down to the wrist, spend a little bit of time around this carpal tunnel, very common area for pathology. Look into the hands, that hypothenar eminence, thenar eminence, see if there's any pain. Another key thing for the palpation that a lot of junior practitioners get wrong is they palpate like this. Meanwhile, the patient is writhing in pain while you're digging around here. So what I'm doing is I'm actually palpating here and I'm watching the patient as much as I am watching what I'm palpating. So I just roll through, see how everything moves, see how she's doing here. Again, thinking of all the anatomy below my hand, looking for any pain or discomfort. Okay, and that would be basic palpation right there. Repeat on the opposite side. Okay? Next thing is going to be range of motion. So range of motion assessment, elbow is pretty simple. What are we going to do here? You're just going to follow the actions that I do. If it's painful or uncomfortable, let me know right away. Okay. And don't do anything you feel will cause you further injury. So from this position, we'll have you flex all the way up and then come all the way back down. And then I want you to go back into a neutral position here and pronate over and then supinate back. And I'm just looking for basic firing patterns as she does that. I could proceed into the wrist. So with your hands out again, bring your wrists all the way up, comparing bilaterally, and then back down and all the way back down into extension. Okay, interesting observation, this wrist moves quite a bit more than this wrist, but I put that in my chart notes. Back to neutral, all the way in, all the way out, and again I could do supination and pronation. Okay, and then into fingers, you can have the patient go ahead and grip all the way down, make a nice fist, bring the fingers all the way back, together, and then apart. And that would take me through basic active range of motion. Beyond this, you can go into passive range of motion. Realistically, I would only do that if I had an index of suspicion of some type of injury. So for passive range of motion for the elbow, pretty simple. You just take the person all the way up, over pressure, all the way back into extension, and watch this one, because this one you can't hurt somebody with. You bring them back in a little bit of overpressure right there. For the supination and pronation can be done, so you go ahead over the wrists, So we pronate all the way over, supinate all the way over. Again, with that overpressure, with that overpressure. Into the wrist, this also counts for a wrist motion as well, supination and pronation. Into the wrist for evaluation, I would go ahead and take her all the way across like that, compressing in that direction, push the opposite way, compressing in that direction, okay? Don't forget there's that little thing called the triangular fibrocartilage on this side, that meniscus of the wrist, scaphoid over here on this side if you're looking at fractures around the wrist right there. Flexion all the way up. What is this like? This is basically a Phelan's test right in that position. This is the one where I'd watch the amount of overpressure you put on, because this is actually a hold where you can hold somebody's wrist and keep them in a position to subdue them if you wanted to. So watch the amount of pressure you put in, because it's easy to hurt somebody this way. But into extension, most people actually love being put back into extension and then actually stretch them out just a little bit. Your assessment is therapeutic for that patient. Okay? And if you were doing a really detailed exam, you could even get into finger specifics and move them around from side to side, overpressure, overpressure. All right, upper extremity rapid muscular resisted range of motion check. The fastest way that I've found to do it is to have the patient do this. So she's going to put her hands up like this. A couple of key things here is her wrists or forearms cannot actually touch each other, because you don't want one forearm to be recruited to help the other forearm. What I'm going to do is interlock my fingers into her hands, and I'm going to pull her, push her in different directions that are going to assess most of the motor supply of the upper extremity. And in fact, Carly, what I'll do is I'll get you to spin that way just a little bit. Yeah. So ideally, this is more for the cameras. I'd keep her sitting straight. I would have been the one to move, but just for you guys. Okay, so I'm going to try and pull you forward like this. Don't let me do it. Hold, hold, and you can see good definition to the biceps. You can even see her pecs are contracting to maintain that position, so you see good contraction there. I'm checking pecs, biceps, and forearm flexors at the same time, because I'm actually trying to roll the fingers out, so don't let me do it. Yep, solid, solid, good. Okay, now I'm going to move you in the opposite direction. I'm going to push you back this way. Don't let me do it. Okay, hold, hold, hold it. Okay, good. So what do I check there? I check triceps, wrist extensors, and the long finger extensors as well. If I needed to do a more detailed examination than that, then you would spend time and do specific muscle testing within it. The other thing I would check as well, maybe, it's not really for the elbow, but I'd also, just for the completeness, I'd also want to check C5 spinal level and have her arms up to the side like this. I'm just going to push down like that, so hold that position, hold, hold, and relax. This will just catch that upper part of the brachial plexus, maybe into C5 area right there. So that'll get you through motion. The next thing is going to be neurologic screen. Remember, your resisted testing and even your active testing was part of your neurologic screen. But other key things you want to do here is upper extremity sensation. So you're going to check dermatomes again, so she can have her hands out in front of her like this. And you're just going to lightly brush, and you're going to give key instructions for the patient. So a couple of key things here. I'm going to lightly brush the skin, and I want you to tell me if it feels the same or different on each side. And I need to do this with your eyes closed, so you can't see how it's happening. Okay? All right, and you just go ahead and proceed.
Same. Same, same, different.
Okay.
Same.
Got to keep the patient honest.
Same, same.
Okay, and a rapid review for which of those regions of the body they were, just so we can get a quick one. For the two true touch patches of the dermatomes, C5, C6, C7 middle finger, C8, and T1 kind of overlaps into here, and then T2 would be way up in this area as well. So if you have a high index of suspicion of specific neurologic compromise, you would also switch over into sharp dull as a further evaluation. Next part for neuro for the upper extremity could include deep tendon reflexes. So DTRs for the upper extremity, she's in a relaxed position there. You can go ahead and strike biceps, is going to be mainly C5 spinal level. Brachioradialis is mainly C6. And then triceps is mainly going to be C7 spinal level. Okay? Other key tests I might do for neuro around the elbow and forearm are Tennell's tests. Tennell's tests actually work out really well. So you can tap the ulnar nerve right here, okay, and you can look for that distal tingling on percussion, it's also known as. You can look for that numbness and tingling over the ulnar nerve distribution. You can have the person, just relax your shoulder for me a little bit, perfect. You can tap over top of the tunnel of Guillain, right on the medial side, again for the ulnar nerve, or you can tap in the midline, Tennell's for the median nerve right in the center. Again, looking for reproduction of numbness and tingling as part of your neural screen. Anything else for neuro? We kind of did it with motor, sensation. You could measure atrophy if it had been a long-standing condition, but realistically, you don't often do that. Grip strength could be there with a dynamometer potentially, but that's really more of a motor function as well. Okay. Vascular, what are you going to do there? You're going to take capillary beds and see how long it takes for them to refill. So you can take fingers, squeeze a finger, and look for that capillary to refill. Should be less than 2 seconds. Even the temperature, this room's a little bit cold right now, I can tell. Okay. Even the temperature of the skin is something that'll tell you how well the blood is supplying that area, okay? You can do capillary refill all the way up and down the extremities as well. So if I squeeze there, you can see the blood got squeezed out of the capillaries and then it refills. Blood gets squeezed out of the capillaries and then it slowly refills, okay? And of course, you can also check pulses for your vascular screen as well. So you've got radial pulse, ulnar pulse, brachial if you're being very specific, and those will be the main areas for your vascular screen. Okay? Referred pain, you can be tricked in the upper extremity because some things can refer pain in the upper extremity. One of the key things being radiculopathies of the cervical spine, trigger point referral patterns, and the one you don't want to miss, especially in men that gives a standard presentation like this, is that pain into the left arm secondary to myocardial infarction. That person's having a heart attack in front of you. You have to be able to recognize that very serious pathology when it's occurring. Anything else that refers in the upper extremity that you can think of? It's a pretty short list, especially as you get further down, there's less and less that refers there. I mean, even a thoracic outlet syndrome could be there, so even if the person comes in with numbness and tingling here, your evaluation of the forearm, wrist, and hand and elbow has to take you back up to the cervical spine. You're not doing your due diligence unless you go all the way back up along that kinetic chain. Okay? Special tests, you will pick your special tests based on the conditions in your DDX list that you want to rule in and rule out.